Dr. Uy, are you ready to get started? Okay, all right. Well, we will go ahead then.
Sorry, you're gonna introduce us, or?
I am, yep. All right. So, good afternoon, everyone. Thank you for joining today's webinar on defeating diabetes. Today, we have a couple of qualified professionals here that want to share some information with you regarding diabetes, the risk factors, as well as signs and symptoms to look for. It is our hope at the end of the webinar that you have a better understanding of diabetes prevention and management. And so a little about ARH. We are a nonprofit healthcare system operating 11 hospitals in southeastern Kentucky and 2 in West Virginia. We are the largest provider of care and the single largest employer in southeastern Kentucky. We are the 3rd largest private employer in southern West Virginia. We operate multi-specialty physician practices, home health services, home medical supply stores, physical, occupational, and speech therapy, and then also retail pharmacies. Our mission is to improve the health and well-being of the people of Appalachia, and these webinars are just one of the many ways that we try to fulfill that mission. So before I introduce our presenters, I just want to go over a few housekeeping tips. The first is the Q&A section and chat will be open throughout the webinar. If you have submitted questions prior to the webinar that are not answered during the presentation, then we will ask those at the end for you. And it is very, very important that you understand that our experts cannot provide specific medical advice or referrals on this webinar. So if you have a need for a referral or have questions about your personal health, you should consult your healthcare provider for diagnosis, treatment, and answers to personal questions. If you do not have a provider, of course, you can join or log on to arh.org, where you can find a listing of our providers that would be happy to help you. So today we have Dr. Uy. She will be presenting today. Dr. Uy is an endocrinologist at Highlands ARH. She completed her internal medicine residency at the University of Connecticut and later completed her endocrine, diabetes, and metabolism fellowship at the University of Kentucky. Prior to joining the team at Highlands ARH, Dr. Uy served as Chief of Medicine in Internal Medicine at Tug Valley ARH for 5 years. So please welcome Dr. Uy.
All right, thank you, Nicole, for that very kind introduction, and thank you for organizing this webinar for us to share some things about one of the topics that's dear to my heart and that I'm really passionate about, and that's diabetes. So ladies and gentlemen, let's get started. So, all right, Nicole, next slide. All right, so diabetes is one of the most common conditions that we have. And in Kentucky, in fact, from 2000 to 2018, the patients that were diagnosed with diabetes has actually doubled from 6.5% to about 13.7%. And in our Appalachian region, the adult rate for diagnosed diabetes is actually about 17%, which is higher compared to non-Appalachian counties, which is around 13%. The sad part is there's a lot of adults that have diabetes but are undiagnosed. Most of the patients, especially if they don't go to their doctors routinely and miss screening tests, some of them actually are, living with diabetes and are unaware of. So really screening and following up with your primary care doctor and getting tested is actually an important part in catching, the incidence of diabetes. All right, next slide. So this was the census from 2019. West Virginia tops the highest rates of type 2 diabetes within the nation, and has about 16.2%, and Kentucky was top 7 that year. And then Next. So in 2020, Kentucky still ranks within the top 10 spot, and we're the 8th highest in the US for diabetes prevalence, with a nationwide median of about 10%. Next slide.
Sorry.
It's okay. So having diabetes does increase risk for morbidity, complications, as well as death. So in 2017, Kentucky had the 5th highest death rate in the nation due to diabetes. And within Kentucky, diabetes is the 6th leading cause of death by disease. And patients with diabetes have medical expenditures that are twice higher than those who do not. So diabetes is really one of the most costly chronic conditions that we have. All right, next slide. So what is diabetes? So diabetes is the disease of the pancreas, and that pancreas is that organ behind the stomach that produces the hormone called insulin. Next slide. So what happens is when a patient eats, so that food that you eat gets broken down into glucose, and that glucose, or the sugar, enters the bloodstream from your intestine. So these are the purple like markers. And then the insulin, which is the hormone that's produced by your pancreas, enter the bloodstream also. So your body uses glucose for energy, but for the glucose to enter the cell, it needs insulin. And so for insulin to work, the insulin has to be identified, and your body has to recognize insulin. And so insulin is kind of like the key for that glucose to enter. So what happened for patients with diabetes, either the pancreas not secreting enough insulin, or the body does not see insulin properly. So that sugar does not enter the cell to be used. So what happened is that glucose stays in the bloodstream, and thus when patients check their sugar, the sugar remains elevated because it does not have the ability to get into the cell due to the deficiency of insulin. Next slide. So for us to understand diabetes, it's really looking at how our body uses glucose for energy. And with patients with diabetes, the problem is that glucose does not enter those cells, remains in the bloodstream, resulting in persistently high glucose levels. There are actually a lot of different types of diabetes, but the one that we're going to talk about today is just the 3 most common ones that we see. So that's type 1, type 2, and gestational diabetes. All right, next slide. So type 1 is also called as insulin dependent. So most of the time, type 1 diabetes are seen in children, although we are actually seeing them also in adults. So what happened with type 1 diabetes is our body produces these abnormal proteins called antibodies that slowly destroys the cells of the pancreas that secretes insulin. So the net effect is the pancreas makes little or no insulin at all. So again, the blood glucose cannot get into our cells and be used as energy. So with patients with type 1, they cannot do without insulin injections, and they must use their insulin shots to control their blood glucose. 10% with diabetes are diagnosed with type 1. So there is a condition that we call as LADA, or known as latent autoimmune diabetes in adults, wherein we have these positive antibodies, but these patients are usually diagnosed later in life, like above 30 years old. And the way that they actually, the type 1 diabetes in childhood as well as an adult are a little bit different, but still the mechanism of how it came about is antibody mediated, and they still need to use insulin. So for type 2, this could be either insulin dependent or non-insulin dependent. So with patients with type 2, the pancreas makes insulin, but sometimes it might not be enough, or the insulin does not work properly, or the body also does not see insulin very well, and that's called insulin resistance. Most of the time, patients are diagnosed over the age of 40, but with obesity rates increasing, we do see type 2 diabetes also in childhood, usually around the age of puberty. They're commonly seen in overweight patients, and in fact, 9 out of 10 people with diabetes have type 2. Next slide. So for gestational diabetes, these are patients that are diagnosed with diabetes during their second trimester of pregnancy and onwards. They're more frequently seen among African Americans, Hispanic, Latino Americans, and American Indians. They're common among obese women and women with family history of diabetes. So it's very important to treat gestational diabetes and to control and normalize maternal blood glucose levels to avoid complication in the mom and in the infant. So the target goals during pregnancy is also different from the target goals that we have with diabetes in the general population. So the blood glucose are actually more stringent. So fasting blood glucose has to be less than 95, and 2 hours after eating, postprandial blood glucose has to be below 120. So it's very, strictly controlled. And that's because we don't want the baby to be large for gestational age, because that can cause like issues with delivery, like complications. The baby can also have like respiratory distress or hypoglycemia, and needing ICU care after delivery. So the more the blood glucose of the mom gets strictly controlled, the better the outcome is for the baby. And after pregnancy, 5 to 10% of women with gestational diabetes are found to have type 2 diabetes. There's a 20 to 50% chance of developing, overt diabetes in the next 5 to 10 years. So it's also important for patients who have history of gestational diabetes to follow up and get regular monitoring, because again, with that history, they are more at risk of developing type 2 diabetes in the future. All right, next slide. So what are the risk factors for diabetes? So in patients who have family history of diabetes, some ethnicity increases that risk. So African American, Hispanic, or Native American race, or having an ethnic background also increases that risk. Obesity, so based on height and weight, the body mass index above 30, or sometimes above 25, being overweight itself also puts patients at risk for diabetes. Physical stress, using certain medications like glucocorticoids, some diuretics like hydrochlorothiazide, some antipsychotic medication like olanzapine, clozapine, and even some birth control medications put patients at risk for diabetes. So injury to the pancreas, like having an infection, surgery, or accident that damages the pancreas, also puts patients at risk. So inactivity, having a sedentary lifestyle, hypertension, high cholesterol, also increases that risk. Age, so the older a patient gets, that also puts patients at risk. The use of alcohol and smoking increases the risk. And then pregnancy also increases the risk because that's a state of insulin resistance. All right, next slide. So the signs and symptoms of having diabetes, especially with type 2, is very, very mild. Some patients may actually have no symptoms at all, and thus diagnosis of diabetes may be delayed. But some of the signs and symptoms, especially if patients have severe hyperglycemia, patients can present with increased thirst, increased hunger, increased urination. Blurred vision can also occur. In type 1 diabetes too, they can have the smell of acetone, especially if they goes into diabetic ketoacidosis. Weight loss can happen, nausea, vomiting, and abdominal pain, or just feeling unwell would be some of the symptoms that patients can report. Next slide. So how do we diagnose diabetes? So there's a couple ways that we would diagnose it. So either we get an A1C, a fasting plasma glucose, or we can do an oral glucose tolerance test. So to diagnose diabetes, you have to have 2 abnormal test results, either of the same test or 2 different tests. So the first one is the A1C, which is a 3-month average of what your blood glucose is doing. So it is glucose that's bound to blood. So if your number is less than 5.6 and below, that's considered normal. So when you hit 5.7 to 6.4, that classifies pre-diabetes, and above 6.5, and 6.5 and above is diabetes. So fasting plasma glucose is also drawn, through the plasma, and it's 8 hours after 8 hours of fasting. So normal is less than 100, and once the value hits 100 to 125, that's pre-diabetes, and then 126 and above is considered diabetes. So for the oral glucose tolerance test, we give a patient 75 grams oral glucose solution, and then we measure the glucose 2 hours after. So if the value is less than 140, that's normal. So from 140 to about 199, that's pre-diabetes, and then 200 and above is considered diabetes. So sometimes when patients also symptomatic, like if they have, polyuria, they're urinating often, they're drinking often because of increased thirst, and their random blood glucose is above 200, that itself can also define diabetes. Next slide. So why do we care about having high blood glucose? The reason is simple. This actually damages blood vessels, both large and small, and causes a lot of comorbidities. So when we talk about microvascular complications, so diabetic retinopathy is one of that, and it actually causes blindness. And in fact, it's the leading cause of blindness in working age adults. It can also affect the kidneys. So diabetic nephropathy itself also is the leading cause of end-stage renal disease, needing dialysis. And also hyperglycemia can affect the small nerves in the hands and feet. And so it can also predispose patient risk for non-traumatic lower extremity amputations, ulcers. So it's really important to keep your blood glucose controlled. Also, for macrovascular complications, having diabetes increases the patient's risk of developing strokes, heart disease, heart attacks, as well as peripheral vascular disease, like those having blockages in the extremities or in the carotid arteries. So type 2 diabetes really affects a lot of areas in our body. Next slide. So in the extreme severe forms of diabetes, so patients can go into what we call as diabetic ketoacidosis, or what we call as a hyperglycemic hyperosmolar state. So DKA most commonly are seen in type 1 diabetics, but also in patients with type 2, they can rarely occur, but can happen, especially in the event that the patient has severe infection, or if they have strokes or heart attacks. So with these condition, patients can develop like altered mental status, confusion, they have nausea, vomiting, really feeling unwell, sometimes difficulty breathing. With type 1 diabetes, they would already have ketones in the blood or in the urine, and patients can actually go into coma. In patients with these severe forms of diabetes presentation needs immediate treatment, or else it would lead to increased complications and death. Next slide. So there are different updates and technologies that makes diabetes patients, handling diabetes a little bit more bearable. So the CGMs, or the continuous glucose monitors, are available. So these are technology that we attach in patients' abdomen or in the upper arm, depending on the sensors that the patient has. But these CGMs monitor blood glucose continuously, either either every minute or every 5 minutes, we can get the readings on the blood glucose. And the best part of these technology is that patients do not have to poke their fingers anymore, except for the Guardian sensor, they still have to need calibrations. The Libre, the Guardians, and the Dexcom, they do also have alerts when the blood glucose drops to a certain level or when it goes up to a certain level. These target levels can be programmed so patients can have ways of preventing a low or preventing a high. So these are good advancement in technology that helps us keep track of blood glucose. Next slide. And so these are also some of the other technologies that are available. So for patients that does not like to keep injecting themselves and feeling those pokes, so the iPort Advance is also a tool that patients can change every 3 days. And then the needle only goes through that port, so the patient really does not feel the poke that frequent. The InPen is also a way of delivering mealtime insulin, and then we do have insulin pumps also that's available. And the newer pumps that we have actually have smart technology wherein patients, automatically, the pump automatically stops when the patient's blood glucose starts dropping at a certain point, and then it would automatically restart without the patient doing anything when their blood glucose are already up to a safe level. And on the flip side too, they have algorithm that enables these pumps to give little boluses or little insulin when the blood glucose starts going up also. So these are just some of the diabetes technology that we have to help our patients. All right, next slide. So in terms of management, so of course, every background starts with lifestyle modification. So diet, exercise, and our endocrinology nurse practitioner, Bonnie, will be talking more about these. So there are oral hypoglycemic agents that we have available, some injectable non-insulin medication, and of course, insulin. Next. And then the goals for the diabetes patients, their blood glucose fasting goals are around 70 to 130. 2 hours after meals has to be less than 180. And for the A1C, ideally would be less than 7. Although, the target blood glucose and A1C are pretty much individualized. So we look at, the comorbidities, the age of the patient, the risk of developing hypoglycemia. So again, the magic number is, less than 7, but really, it really depends on the patient itself, because for elderly patients with multiple comorbidities, the goal does not have to be less than 7 because the risk would be more than the benefits for those patients. Next slide. So this is kind of just like a nutshell summary of the medication that we commonly use for diabetes. This is kind of like a busy slide, but this would be another whole lecture. But in summary, we do have some oral anti-diabetes medications like metformin, this SGLT2 inhibitors. They're marketed as Jardiance, Farxiga, as well as Invokana, to name a few. The GLP-1s are non-insulin injectables that's marketed as Ozempic, Trulicity, Bydureon, Victoza, to name a few. The DPP-4 inhibitors are marketed as Tradjenta, Januvia, to name a few. The thiazolidinediones are like Actos, sulfonylureas. These are the common ones. It's a cheaper medications for diabetes, glipizide, glimepiride, and of course we have different forms of insulin. Next slide. So Bonnie's gonna be talking more about hypoglycemia, lifestyle modification. So she's our endocrinology nurse practitioner, and she also helps take care of our diabetes patients in the clinic. Bonnie, I'll turn the screen to you.
Hi, thank you. So with hypoglycemia, which means low blood sugar, there's things that can cause it, such as skipping meals or not eating enough. If you're more active than normal, or if you take too much medicine, it could cause hypoglycemia, which basically means low blood sugar. And that can cause a variety of symptoms such as shaking, sweating. Yeah, go back to the next slide, please. Anxiousness, dizziness, increased hunger. You may feel like you have a rapid heart rate or just feel like generally weak and fatigued. If you feel those symptoms, then it would be important for you to go and check your blood sugar to make sure that it's not, in fact, low. Next slide, please. So if your blood sugar is low, what do you do? So the general rule, if you have a low blood sugar, so if it's less than 70, or in patients with without diabetes, it could actually be much lower than that. But if you eat or drink 15 grams of carbs, which can be a tablespoon or 2 packs of sugar, a tablespoon of honey, 4 or 5 crackers, about 4 ounces of orange juice or a sugary soda, and then you wait 15 minutes and then recheck your blood sugar to see if it's beginning to rise. If it's not beginning to rise, then you repeat the process again. With diabetes, it's important that you wear a medical alert bracelet. That way, if someone does find you and you're in trouble, they know to check your blood sugar to find out if that's the cause. Next slide, please. So on days that you're sick, diabetes requires more intense monitoring, just because when you're sick or if your body's under stress, your blood sugars tend to fluctuate even more than on a regular day. So you may need extra insulin to compensate for the illness, or if you're not able to eat, you may need to increase your oral fluid intake if you're not able to eat food. So every hour, sip 8 ounces of sugar-free, caffeine-free drinks, including water, sugar-free soft drinks, or tea. And then every third hour, sip 8 ounces of one of the following types of soup, like broth, bouillon, or a canned clear soup. If your blood sugar is running low, you may need to have something that has a little bit of carbohydrates in it. So a half a cup of orange juice, or a half a cup of sweetened caffeine-free soft drink, or a popsicle that may have sugar in it. Next slide. So how do you prevent diabetes? So preventing diabetes, the most important way and the most reliable way to prevent diabetes is by your lifestyle. So interventions like maintaining a healthy diet and doing moderate intensity physical activity at least 3 to 4 days a week can help prevent diabetes. A large study showed that if you lose just 7% of your body weight, it can actually reduce your risk for diabetes in people who are obese. Development of diabetes was reduced by 58% over 3 years. Next slide. So diet, of course, is a really important part of diabetes management and diabetes prevention. Eating regular meals, limiting the intake of fat, sugar, and salt, eating an adequate amount of fiber, and eating a variety of foods every day. So if you look at the plates that are shown on this slide, you can see that the non-starchy vegetables and fruit and vegetables have almost double the amount of carbohydrates. Carbohydrates are foods that contain sugar and fat, and can increase your blood sugar. Next slide, please. And you'll see on this food pyramid that you see that, of course, on top you have fats and oils. You want to use those sparingly. And you can see that if you look at the milk and yogurt and cheese and meat, if you look right under that, fruit and vegetables have a much larger serving requirement. Okay, next slide. So exercise, physical activity promotes weight reduction and improves insulin sensitivity, and that lowers blood sugar levels. However, it does increase the risk of hypoglycemia. So when you're exercising, it's important that you bring a snack with you. So according to the ADA, it recommends 30 minutes of moderate to vigorous intensity exercise at least 5 days a week. This includes walking, bicycling, swimming, dancing, gardening, low impact aerobics. And it's important to know that you don't have to start with 30 minutes. You can start with your own comfort level and build your way up. And of course, before you start any kind of exercise regimen, you should always talk to your doctor about where they think is a good place for you to start. Next slide, please. So what should you bring with you? What should you wear when you're exercising? So always bring or wear comfortable clothing, wear appropriate footwear, especially in diabetes. It's important to wear good fitting shoes, drink plenty of fluids, check your blood sugar before and after exercise. Like I mentioned before, wear your alert bracelet in case you were to have trouble while you're exercising, and make sure that you carry a snack with you should your blood sugar drop unexpectedly. And it's safest to exercise about 1 to 2 hours after meals, so that way your sugar is going to be at its highest. Next slide, please. So some things that you can do to take care of yourself is with diabetes, you need to monitor your blood sugar and make sure that you're checking it every day. Monitor your body weight. Keep an eye on your blood pressure and check that routinely. Keep good personal hygiene to reduce the chances of infection. And then, of course, your lifestyle and diet modifications, routine physical activity, stopping smoking, and making sure that you perform routine foot inspections and get proper foot care. Next slide, please. So in addition, it's also important that you follow up with your regular family physicians and also get a routine eye exam. You should have an eye exam at least once every year to monitor for any diabetic changes that might be present. Also important to get your regular blood tests, including your blood glucose and cholesterol test, having your A1C monitored to monitor the progress of your health. Also important to get routine urine tests and regular foot exams. Next slide, please. So prevention of eye disease. In patients with diabetes, diabetic retinopathy is, of course, as Dr. Uy mentioned, the leading cause of blindness in working age people. And so controlling your blood sugar helps significantly reduce this risk because it stops the damage to the blood vessels that supply your eyes. Also controlling your blood sugar, blood pressure, your cholesterol, and having an annual eye exam from your eye doctor is important in prevention of eye disease. Also wearing eye protection. If you're doing something that has the risk of something, getting into or injuring your eyes, it's always important to wear eye protection. Next slide, please. dental care. So in all patients, but especially diabetics, it's important to keep routine dental care. Make sure that you're seeing your dentist at least every 6 months, brushing after each meal and snack using a soft toothbrush, and to make sure you're brushing against the gum line and brushing gently, flossing at least once a day, keeping your dentures clean and well-fitting, and use of an antimicrobial mouthwash, and close observation for periodontal disease. As I mentioned earlier, with diabetes, it's an increased risk of infection. Next slide, please. Prevention of heart and artery disease. So to prevent the heart risk, of course, keeping your blood sugar again is one of the important prevention methods. Also, keeping your blood sugar less than 140/90, keeping cholesterol levels under control, and physical activity for at least 30 minutes most of the days of the week. And you'll see on the right-hand side of this slide, there's a table that shows what your cholesterol goals should be. Okay, next slide. And for diabetes and for patients with diabetes, one of the most important things that you can do for yourself is take care of your feet. With diabetes, nerve damage and poor blood flow increase the likelihood of amputation. So if every day you should check your feet in a mirror and inspect for any cracks or dry skin, any areas that you can see any skin breakdown, and especially in between your toes. Look for cuts, sores, blisters, redness, or calluses. If your skin is dry, you can put lotion on your feet after washing and drying them, but don't put lotion in between your toes because that can increase the risk of bacterial growth or of athlete's foot. Make sure you cut your toenails once a week and cut them in the shape of your toe. Make sure that you don't cut them too short into the cuticle, or you could risk getting ingrown toenails. Next slide, please. Always wear shoes or slippers on your feet to protect your feet from injuries. It prevents any risk of any punctures. Always wear socks or stockings to avoid blisters. Don't wear socks or knee-high stockings that are too tight or are too tight below your knees that could impair your circulation. Wear shoes that fit well so they're not rubbing or irritating the skin of your feet and causing blisters. Inspect the inside of your shoes for sharp edges or objects that might cause injury to your feet, and get a diabetic foot exam at least annually by your family physician. Next slide, please. And be proactive. An ounce of prevention is more than a pound of cure. Thank you.
Okay, so thank you very much, Dr. Uwe and Bonnie. So let's see if we have any questions here. It does not look like that we have any that were submitted while the presentation was going on. So if you want to ask any questions right now would be a great time. Bonnie and Dr. Uwe would be happy to answer anything that you may need to know.
So there is a question from the chat box that are diabetes patients at increased risk for COVID hospitalizations? And the answer is yes. So having diabetes increases the risk of patient getting COVID infection and actually increases the risk of having severe COVID infection needing hospitalization. So we ideally really would suggest patients with diabetes get their COVID vaccine.
Good question. Do we have any more? Okay, well, I guess this concludes our webinar for today on diabetes. Dr.
Daniel, so Daniel actually asked Bonnie. Bonnie, did you see the question?
I did.
I apologize.
Question. So any suggestions for navigating diabetes around the holidays? So my suggestion to patients with diabetes, you know, there's a lot of food that you maybe want to eat, or of course there's always a large spread at the table. So what I suggest is to pick the things that are most important for you to have, and the things that you can do without, or you can always pick some things for one meal and then make yourself, with some leftovers, a plate for the next day of the other things you didn't get to have at that time. So, with diabetes, it's important that you try to, for women, you should stay between 45 and 60 grams of carbs per meal. So, if you're going above that, which is very easy to do with Thanksgiving, it's of course going to cause your blood sugar to rise. So I think that my best advice is just pick the most important things, and then, you can maybe have something else, of course, at another meal. So there's another question. Are there support groups available? There actually are support groups available. With the Big Sandy Diabetes Coalition, they're offering support groups in some areas. Unfortunately, due to COVID, our support group here at Highlands had been postponed. And hopefully in the future, as COVID subsides, we'll be able to open that again to the public.
And a good resource is the American Diabetes Association. So patients are welcome to look at their website. There are patient resources available in their website.
Do we have any more questions? Okay, there is a question that's been submitted, and it says, what is what is A1C 5.8 considered as?
It's pre-diabetes. So again, if it's below 5.6 and below is considered normal. So once you hit 5.7 and above, that would be considered, so 5.7 to 6.4 is considered pre-diabetes.
Okay, I don't see anything else at this time. Okay, so Dr. Uy, Bonnie, once again, thank you very much for joining us and giving us just all this great information about diabetes, especially like we said with the holidays coming up. Hopefully everyone will be doing a great job at managing those diabetes symptoms during the holidays. Thank you all for joining today. Hopefully you are better informed, and we thank you for your time.
Thank you for having us. All right. Have a nice day.